The patient should be positioned supine with the neck in neutral position. In trauma patients, care must be taken to protect the spinal cord, as a cervical spine injury must be presumed until radiologic and clinical examination have excluded this diagnosis. Sterile prep and drape the anterior neck if time permits. Palpate the cricothyroid membrane below the thyroid cartilage in the midline. Stabilize the thyroid cartilage firmly with one hand and make a transverse incision approximately 2 centimeters in length down to and through the cricothyroid membrane. Insert the tracheal spreader down the distal trachea and gently spread. Alternatively, if a tracheal spreader is not available, insert the handle of the scalpel transversely through the wound into the trachea. Rotate the scalpel handle 90 degrees to enlarge the opening in the cricothyroid membrane. With the tracheal spreader in place, insert a tracheostomy tube and remove the tracheal spreader. Alternatively, a small retractor can be used if a tracheal spreader is not available. Inflate the cuff with 5 milliliters of air. Attach an ambu bag and ventilate the patient with 100% oxygen. Auscultate the chest to confirm equal and clear breath sounds bilaterally. Control superficial bleeding either with direct pressure or with hemostats and silk ligatures if necessary. Suture the tracheostomy tube to the skin with 2-O-proline suture. The patient should be positioned supine with the neck in the neutral position. In trauma patients, care must be taken to maintain C-spine control. Sterile prep and drape the anterior neck if time permits. Palpate the cricothyroid membrane below the thyroid cartilage in the midline. Attach a 5 milliliter syringe to a 12 to 14 gauge angiocatheter and puncture the skin in the midline over the cricothyroid membrane. Direct the catheter inferiorly at 45 degrees to the skin. Gently advance the catheter while aspirating. Stop once air is aspirated, which confirms position within the tracheal lumen. Advance the catheter over the needle, down the distal trachea, and withdraw the needle. Attach a 3 mm pediatric endotracheal tube adapter to the hub of the catheter. Attach a Y connector to the oxygen tubing and to the pediatric endotracheal tube adapter. Maintain oxygen flow at 15 liters per minute. Provide ventilation by intermittently placing the thumb over the open end of the Y connector for 1 second and off for 4 seconds. Landmarks used for tracheotomy are the thyroid cartilage and the sternal notch. The incision is usually made approximately 2 finger breadths above the sternal notch. An incision of about 1 to 1.5 inches is made transversely. Strap muscles are separated vertically or transversely, and the tissue between them is divided. The thyroid isthmus sometimes needs to be retracted inferiorly or divided. The trachea is identified and separated from the surrounding tissues, so the 2nd to 4th tracheal rings are identified. 2 stay sutures are then placed in the trachea at the approximate level of the 2nd or 3rd tracheal ring. The patient should be positioned supine with the neck in the neutral position. In trauma patients, care must be taken to protect the spinal cord, as a cervical spine injury must be presumed until radiologic and clinical examination have excluded this diagnosis. The trachea is incised longitudinally. The opening of the trachea is then spread using a tracheal dilator. For urgent tracheostomy, a number 6 endotracheal tube or a tracheostomy tube can be used. The endotracheal tube or tracheostomy tube should initially be inserted perpendicular to the trachea to avoid placement of the tube in the pretracheal space. A number 6 endotracheal tube can be used in emergent situations for either cricothyroidotomy or tracheostomy. The endotracheal tube is inserted to a depth of 8 to 10 centimeters. Care needs to be taken not to insert the endotracheal tube too far, or unilateral bronchial intubation may occur. If a formal tracheostomy tube is used, it should be inserted to the level of the strap used to secure the tube. It is important to confirm tube position in the trachea by confirming that bilateral breath sounds can be heard in the chest. An end-tidal CO2 detector can be attached to the endotracheal tube or tracheostomy tube to confirm position in the trachea as well. It is imperative that the tube is sutured or held in place to prevent accidental dislodgement, which may be fatal.